Today's episode is Sharing Outside of the Box. Our moderator is Joy Harris. Joy is the Public Health Modernization and Accreditation Coordinator at the Iowa Department of Public Health. In her role, she facilitates the work of the Public Health Advisory Council. One of the council's main responsibility is to make recommendations to improve Iowa's governmental public health systems. In her role as accreditation coordinator, Joy is responsible for coordinating the department's documentation and preparing staff and partners for the accreditation site visits. Additionally, Joy provides technical assistance to local health departments in the areas of quality health improvement and accreditation. So at this time, I'll turn the program over to Joy. Thanks, Joy.
Hey, thanks so much. Thank you all for being with us today. As Kate said, our theme of today is sharing outside the box. We are going to be talking about cross-jurisdictional sharing and new models for delivering public health services. I really feel like we're sharing with you two innovative models in Iowa of how cross-jurisdictional sharing can happen and how we're trying to use it to achieve goals to deliver public health services. We're going to discuss how these public health leaders have designed and implemented these strategies in order to better serve their populations and to address funding necessary for their work. So I'm going to waste no time getting to them, but let me introduce them really quickly. Shelby Kruna and Carrie Prescott are together on your screen. Shelby is the administrator of Hamilton County Public Health. Carrie Prescott, with her, is the director of Webster County Health Department in Environmental Health. And then Joan Gallagher is the administrator of Taylor County Public Health. So how we'd like to start today is just have you meet them. It's no good just for me to know them. You all need to know a little bit about them as well. So Joan, Carrie, and Shelby, I'd like you to introduce yourself. I need you to talk about the size of your county, the counties you're working with, how long you've been working together, and the work you've done with shared services. And so I know that was a lot of things. So if you need me to help remind you, just let me know, okay? Awesome.
Okay.
Carrie, I'm going to have you go first.
Okay, I'm going to first defer to my partner in Hamilton and have her give her a update of Hamilton County.
Cool.
Hi, I'm Shelby, and Hamilton County is a smaller county. We have about 15,000 residents currently, and I've been the administrator there 11 years, but I have 23 years in public health. I moved from a large county to a small county, so sometimes I hope that gives me a little different perspective because I've kind of seen both areas, large and small. What was the third thing?
What work you've been doing with shared services?
Currently, we share, with the emergency preparedness, we're in Region VII together with Webster County, and then it's maternal health, WIC, like childhood lead, tobacco are kind of the main areas that we program share.
Awesome. Thank you.
You're welcome.
So I'm Carrie. I'm from the Webster County Health Department. Webster County has a population of approximately 36,600 people. The largest city in Webster County is Fort Dodge, and Fort Dodge has a population of about 24,500. We're very rural. Shelby's county and my county are in the northwest part of the state, and primarily agricultural and industrial are the primary work industries in our area. I have been with the health department for 21 years. Somebody sighed. The original alignment of the four counties was our WIC Maternal Child Health Services grant, which really was the beginning basis of our partnerships. The model that was implemented with the WIC Maternal Child Health contract, and we'll talk a little bit more about that later, but that model has evolved and really changed over the last couple years. We have matured from 4 counties with that original contract to 15 counties. being aligned for maternal child health services. And like Shelby said, we try to integrate other opportunities that may present themselves as far as contracts if our neighboring communities are a little too small to write for contracts. So we have maternal child health, WIC, tobacco, lead poisoning, the Region VII emergency preparedness. We're also part of an accountable care organization that focuses on 6 counties. Our state innovation model is also part of our embedded multi-jurisdictional processes. So we can talk a little bit more about that later. So I think that's everything I'm supposed to talk about.
Perfect, thank you. All right, Joan, you're up.
Okay, so Joan from Taylor County. We're in southwest Iowa. We border Missouri and about 70 miles away from Nebraska. My county is about 6,200 people. We have 2 population centers, I would say, Bedford and Lenox. Each town is about 1,400, and Bedford is the county seat. The catalyst, again, like Carrie said, for our multi-jurisdictional sharing was our maternal and child health grant. We started with 1 county and started to expand as many as 6, but now we just have 4 for our maternal child health. And then we also partner with another county for public health and Medicaid home health. I've been in the business for, at least with Taylor County Public Health, for almost 35 years, and the last 6 as the administrator. So I hope that's all that I needed to answer, Joy.
You do great. Okay, so let's start. I need you all to think back when you were considering sharing of services and cross-jurisdictional sharing, and talk to us a little bit about how did it get started. Carrie and Shelby, I'm going to have you 2 go first.
I was going to say, well, in some of the areas predated me, because some of the sharing was already in place. But when I think back to like our lead program, that's been one of our more recent endeavors of sharing. And it became apparent that the amount of money that was being saved for Hamilton County really wasn't providing enough services. But if we were able to band together more counties, I felt it enhanced the ability for us to do childhood lead poisoning prevention.
Okay.
So because we already had a partnership through the WIC and maternal child health, it was just natural then when that grant became available that those partners came together around lead poisoning prevention also.
Okay.
And I would agree with that. So as opportunities for funding and opportunities to provide more direct services were available in our service area. And our service area, when I state that, is sometimes Webster County only, sometimes it's all 4 counties, and sometimes it's all 15 counties. It depends on the service that's being provided or that the opportunity is based around. Even though we have a large population within our 15 counties, there are still some opportunities that we would not be able to write for just because of the population that they would be serving. So for instance, like a HIV grant, we may not have enough of the targeted population to serve the requirements of the grant. So when opportunities present themselves, we go to all of our first partners, which is usually the original 4, and make sure that it aligns within our community health needs assessment, it aligns within what the community wants, and really has some thorough conversations around, is this something that needs to be provided in the community? And if so, then we start talking about workforce. So originally it just all started around necessity to band together to have the services, and then it's really just evolved since then.
Okay. Joan, how about you? What prompted your sharing to get started?
Basically, we were asked. I'm really going back to the 80s when I started, and that's when our maternal and child health services started. But even previous to that, RLDS Social Services had a contract to provide homemaker services with Department of Human Services. So that was a regional sharing. And then they went away, homemaker services changed, and the maternal and child health opportunity came about. So we started as a single county and then added up to 6 counties to that contract. And again, like as Carrie said, it's based on necessity. You know, when you look at the population of Taylor County, it's not that much, obviously. And our big population center would be Page County to my west, and they're about 15,000, and that's as big as I get. Montgomery County is another county that I partner with, and they're 10,000, and Fremont County is almost 7,000. So everybody has their own definition of rural. This to me is rural. We needed this in order to make the service viable. A lot of these grants, as everybody knows, they don't pay for everything. So if you want a whole body to do something, you're going to have to piecemeal it out to full-time equivalents. And really, that's how we got started. We were asked, and then out of necessity to make it work, we looked to our neighbors.
Okay, so let's talk a little bit more about necessity, because you both touched on that. So necessity is the motivation, part of the motivation, but what other things motivated you to do more sharing of services? Carrie and Shelby, I'm going to go back to you guys again.
So for us, the motivation was once we had a model and could see the gaps in the services that were not provided, and from Webster County's viewpoint, we felt that it was kind of the right thing to do to make sure that oral health services and child health services and expecting mothers could receive some standardized services through the maternal child health and the WIC programming. We saw it as opportunities to really enhance and have a better delivery system by utilizing our local public health in each of those counties to do what was right for that targeted population. A lot of our counties have a high child abuse rate. It just felt like that this particular program fit the best within all of the different programs and opportunities provided by our public health agency. And we really wanted to align our services with our neighboring communities, because we're kind of a commuter community as well. So people will come to Fort Dodge and work, but live in other communities that some, as far as an hour away. So we just thought it was very important, and our Board of Health took that mission as well, to make sure that we were trying to standardize and hit as many children with the necessities, with the services that we could.
And I would also add that Carrie's right. It's really nice, especially in the WIC maternal child health programming, because they could live in Hamilton, they could receive their services in Hamilton, but they can also receive their services in Fort Dodge since we're aligned. And so if they're coming to Fort Dodge to go to Walmart and it just happens to work better to hit the WIC clinic in Fort Dodge this month, they can do that. So instead of waiting, because like WIC in particular is 2 days a month in Webster City. So if you have your baby 2 days after our clinic is closed, you either have to wait or travel.
Okay.
It works.
Do you think that the same motivation keeps you going, or has the motivation changed a little bit?
I think as we're looking forward, our motivation is changing because Carrie and I just had a discussion around what should a county expect from their public health, their governmental public health system. Mm-hmm. Services are we providing or not providing, or how can we enhance what we're doing going into the future? Knowing that budgets are tightening and funds are limited, but also doing what's right for the people who live in our counties.
Okay. Anything you want to add, Carrie?
No, she articulated exactly right. So
Awesome. All right, clear. So we were talking about kind of maintaining your motivation to keep sharing. Do you want to talk a little bit about what keeps you going?
Critical, obviously, to me, it's survival. I can't do this without my partners. And so listening to Carrie and Shelby talk about the differences, you know, obviously, like I tried to say earlier, each county has their own personality, not only from their residents, but from the various boards. And that's one thing that we do for the cross-jurisdictional sharing, not only required for some of our grants, but necessity to survive, to talk to the various boards of health and boards of supervisors, like with my Adams County partnership to the north. That's pretty much public health services and home health services. And they had to be okay with that in order to move forward. So we can't afford not to keep everybody in the loop of not only what are we doing now, but what do we hope to do, and make sure they understand what our goals and plans are. So if they're like, no, I'm not so crazy about that particular idea, you know, I'm lucky I do have support from the Board of Supervisors, which I think some states would call them county commissioners, and they support me generously. So they need to be in the loop and know my plans, and not every one of my subcontractors has that relationship. But I think that's the interesting part of my job, is you get to see how other boards of health and other boards of supervisors operate, and you can take the best of that, and you can also learn from the challenges.
Yes. So if you had to start over, right? Fresh place, the need hadn't been identified, and then all of a sudden it becomes identified. Oh wait, I'm jumping ahead, but that's okay. What would you do differently?
So I'm going to give it from a Webster County purview. Really, I don't know if we would have done anything differently to engage our partners and to engage the model that has kind of been laid in front of us. We were very diplomatic in making sure that it wasn't our perspective kind of shoved down the throats of our neighboring communities. We did a really, we made sure that we met regularly. We made sure that it fit within their plan. We made sure it fit within their vision. We were very deliberate on most of our coordination of services. As we move forward, I would say we probably need to be a little bit more deliberate on fiscal necessity within those communities, and maybe doing more of an assessment around the Board of Supervisors view and their sustainability options of their local public health. We have a wide diversity between governmental public health and then hospital-based public health. So I would say with the changing times, we probably will need to, well, not probably, we will need to do some type of fiscal assessments and really dive into what is the appropriate buy-in. Because if I have a vision of a strong public health network, but a Board of Supervisors has a vision of downsizing the public health network, those two worlds will never work. So, times are changing. And so as we move forward, those will be definite pieces that we need to make sure we're starting to talk about and articulate.
So since not everyone on the call is going to be from Iowa, can you give like your quick 1-minute role of the Board of Supervisors in Iowa?
The Board of Supervisors in Iowa are fiscally responsible for the governmental public health system. Now, and it's a wide array of things. Some of them contribute nothing to their local public health department, where others are quite heavily funded by their Board of Supervisors or local tax dollars. and then you have some that are kind of in the middle. So it's a real wide array, but really their job is to appoint the Board of Health and then to help manage our fiscal budget.
Got it.
And
Okay,
that,
sorry.
and that brings up the diversity. So, like for instance, in my county, we receive no county allocation of dollars. They provide us, space and IT work, but they do not allocate X amount of dollars for the operation. So in my county, I'm in a special revenue account that I have to run like a business to cover my expenses because I have no backdoor fill from the county supervisors, which has been a positive because they've now allowed me to keep a running, like a checkbook. So anything that I have above and beyond stays in my public health department. So I have a checking account per se to tap into when I need funds. I need to be very cognizant of that as I move around and deal and coordinate care with my neighboring communities that, like Shelby mentioned, that might be asking for, many hundreds of thousands of dollars from their supervisors. And then I just need to have an awareness that of those financial crunches and how do we make sure that we integrate and coordinate and collaborate and educate as we move forward what is, like what Shelby said, best for the community.
Shelby, did you want to talk about starting over going back to my other question?
I think there probably isn't much that would be different. Again, I think educating each other in our coalition, like say our 4 counties or whatever, just having an understanding of what role their boards of supervisors play, what their role their Board of Health plays, and then again looking at the financial issues in each county is somewhat different.
Okay, thank you. So next question, if you could start all over with sharing, what would you do differently?
Me?
Yeah.
I would have taken it slower, especially in Adams County. When we were asked, that was February of 2016, and Adams County had been employed by a hospital who had administration out of state. So when that hospital decided they weren't going to do home health anymore and public health was tied on to that, they wanted to get out of there lickety-split. So that first conversation happened in February, and that same year, July 1st, we were partnered.
Wow.
We were lucky enough to hire 3/4 of the staff that had worked for the previous entity, which was great. But we weren't ready. Our branch office wasn't blessed by Medicare to be staffed. So we had crammed more people. And anyway, I would have just taken it slower. A few more months would have been nice.
How much time would you have liked to have?
3 more months, obviously. If we could have waited until we were blessed by Medicare to physically locate in our branch office, that would have helped.
That's still not much time, Joan.
No, it's not, but I go by, give me my bare minimum.
All right. So, the next question. As you think about kind of your journey, you both have described, talk to us a little bit about challenges and obstacles that you've encountered along the way, both what they were and how you overcame them. And if you didn't overcome them, how come you think that is? Joan, I'm going to have you go first.
Okay, challenges, I think Carrie and Shelby may say this too, is staff turnover, especially with subcontractors, because we're not hiring those people directly. Mm-hmm. But I feel like I have the responsibility to orient them to the various programs that we offer through contract with them. So if there's a high turnover, then you're spending a lot of time orienting new staff and not enough time getting the work done. As long as I have one key person that remains steady in each subcontract opportunity, I think I'm good, and that's what I need to have. It really helps to be flexible. I don't think you can be in public health without being flexible and without going with the flow, because not a whole lot goes as planned when you think you start your day. And then you open your email or you answer your phone and it's like, okay, we're going to deal with this.
Yes.
It's also need to learn to say, let me think about that, and instead of caving into the demand, give me an answer right now, when it's not an answer that might not be best for that situation. And one of the most important things is appreciate the differences. I always have this saying, it's the world according to Joan.
Mm-hmm.
But I know it's not the world according to Joan. I am just one of a bajillion people on this planet.
Mm-hmm.
So appreciate the differences and be ready to listen to what other people have to say.
Very good. All right, Carrie and Shelby, it's you guys.
I think one of the challenges that still remains is that we're still a small staffed health department. So when we program share, it might only be a fourth of one of my staff person's duties to perform. We'll just say like the tobacco grant. And so sometimes it's hard to get the right person on the right task when you're small. Plus, it also then you run into, should I do a home health visit, or do I work on this prevention grant, or do I do WIC, and so you have competing interests, and maybe they're really good at one of them, but they may not be the best at all of them. But because you're small, they wear all those hats.
Mm-hmm.
And I would say from kind of the originating site, like being like the main contractor for our subcontracts, so our challenges are a little differently. So we are a larger public health department. So our challenges is always to make sure we think like a smaller department, so we're not imposing additional rules and regulations and forms and changes upon our partners that make it too cumbersome to work together. Our challenges are more administrative, to make sure that we do auditing and make sure that we have some type of standardization around forms, making sure that people are using correct consents. It takes a lot of communication and coordination and delegation from staff to our subcontracts to say we need a point of contact to make sure that these things are followed to be a subcontractor. And it just takes a lot of communication and coordination. And in some situations, not Shelby's, but in some situations, if it's not deemed as an important activity, sometimes it gets moved down to the bottom of the pecking order of the pile. And so for us to softly go in and explain the importance of whatever requirement that we're held to is standardized across all of our neighbors. It just takes a lot of coordination, and it's that's probably one of our biggest challenges.
So what have you tried to improve communication? Or, because as we keep talking, I keep thinking the communication must be huge, and there's so many different partners to communicate with for all of you. Do you have any tips around good, strong communication?
I think when we first started with our maternal child health region, well, when I was here, we had face-to-face meetings because we were a smaller group. Now that group has expanded, so we don't have as much face-to-face meetings, but I was just sharing with Carrie, maybe we need to do more Zoom meetings, if a new form comes out, so everybody can get on at their own location and all learn how to use this form at the same time, instead of her staff getting 25 different phone calls and our staff like, oh, we got another new form. Oh no, I don't know what to do with it,
Yes.
And so from our perspective is we've changed a lot of our table of organization, And one of the pieces that we heard from our subcontracts is, am I supposed to call employee X about this? Or am I supposed to call employee B about this? Or am I supposed to call you about this? And so we really approved a table of organization to define our roles and responsibilities, and our subs have an absolute person to coordinate with. We try to do that balance between having meaningful meetings and not just meeting just to have a meeting. And so we are looking at some other opportunities to try to connect virtually and things like that. But, communication, is still an issue, but we're still trying to put in some activities and some strategies to reduce it.
Cool. Joan, how about you? Any tips on communication?
We're still small, so we're still in the face-to-face meeting mode, and we have several different opportunities for that. I have our public health administrators meeting. It's bigger than my 4 counties, but that's one opportunity that meets quarterly that I'm lucky enough to be in the same public health region as my maternal and child health folks. I don't know that Carrie and Shelby have that opportunity. With our preparedness folks, we get together every month. And then I host our maternal and child health quarterly meetings among those partners, and we rotate amongst our counties, so it's not always at one place. Again, we're still small, so we talk business, but it also helps us get to know each other on a personal level. Even I consider us small, but we have a staff of 14 in my office. But as alluded to, everybody wears different hats. I only have part of me, a nurse and an eye smell dental hygienist, and a clerical person dedicated to my maternal and child health and lead and oral health contracts. So that's kind of small. But most of the time it's working. I'm a lot of times changing my desk, so if all else fails, they can get a hold of me. Otherwise, my clerical person, but we still meet face to face. I find that very, very helpful.
Okay, thank you. All right, so an important part of Public Health 3.0 is really about leadership and public health taking a role as a leader in health in the community. So I wanted to talk to you guys really briefly about what leadership skills or competencies you feel like have helped you when you think about sharing of services in particular. Joan, I'm going to have you go first.
Okay. And I knew you were going to ask this question, and to me it's a scary one because I don't think of, Joan, you're a leader. I just do what I do. I don't necessarily think I'm a negotiator, but I do listen. So I know, like, if my home visiting folks that I don't have a subcontract with, but I need help getting the oral health message out. Hey, if I give you a couple hundred toothbrushes, would you tell your home visiting families about oral health? So to me, that's negotiating in some respects.
Yeah.
Again, I am organized. I have been accused of that, and some people think I'm a little anal about that. But if I don't write it down and if I don't go in that mode, I will truly, truly be lost because you guys know we wear many hats. It's you can't keep it in your head anymore. So I try to write it down on my calendars and months out as much as possible, and when is this grant due and when is that report due and what do I need from whom in order to complete that. I still try to have some opportunity to delegate as much as I can, and then boots to the ground. To me, I like meeting with my subcontractors and their boards. That to me is my favorite part. Then as far as moving people, I, again, meet with the various boards, interagency meetings, or have people assigned to go to those and report back to me. So I get an opportunity to learn what other many hats the people I work with have to wear. So that in a nutshell is what I can think.
Very cool. Carrie and Shelby, how about you?
For leadership skills, I thought a lot of facilitation skills are really important. Active listening skills are really important because sometimes we come to the table and we may not say all that we really want to say. So trying to, hone in on key, or if somebody's really quiet, and not participating in the conversation, being able to read your community and the people. I think when you talk about cross-jurisdictional sharing, you really have to have trust in your partners and know that what they're saying is they're going to follow through on.
Yeah. How about you, Carrie?
So I think of leadership, some of the viewpoints that we've had from our perspective is we try to encourage go do, and we'll figure out how to pay for it and how to chart it and how to figure it out. Take care of the people in your community. In our world, everybody's got fires. We have wonderful working relationships with our DHS system, and sometimes we're not available immediately to have that question, what form, or can I do this? So we very much empower our subcontracts to go do, and we'll figure it out. It's a constant changing environment. And if we don't trust, if we, meaning Webster County, doesn't trust the subcontract people to do the work that we've charged them to do, then it's not going to work. So I have to trust that Shelby's going to tell her staff as well, go do and do the right thing for your community. Communication, like Shelby said, is key. And listening, listen to not interject or to solve, but listening to plan is a big component, and making sure that you have everybody's point of view before you move forward with any kind of big decisions. Let's see. Moving people. We're not really about like moving people. It's more utilizing our workforce and our capacity and educating staff sometimes on thinking differently and outside of the box. And then, some of the things is we can sit around the table and we think that it's all going well, but sometimes we still have silos. So we need to break down our silos. And then we, as the kind of the lead agency, need to give that assurance that the funding piece will follow the work that you're doing. And so and that's a goal all around, trusting and the networking and the partnerships that you have, and that they don't happen overnight. So
yeah. So I have two more questions for our panelists, but I'd like to invite other people, if you have questions, to please put those in the chat box or the question and answer section at this time. Carrie and Shelby, why I've got you front and center on my screen, are there leadership competencies or skills that you wish that you had, or resources that would be available to you to make this easier?
I think we're both rock stars, but
No question.
I would say one of the things looking forward in the future is looking at some financial analysis. So even understanding, I think we both do well in cost reports, but I'm not sure everybody does well in cost reports. And how do you determine what a program really costs?
Yeah.
So when I look to the future, we're all going to have to know that, whether we're asking for more money from our boards of supervisors or, coming together as a group, what does this look like over a multi-jurisdictional area? I would agree.
Okay. Joan, how about you?
Money is always a factor. We don't have that money tree in the backyard. I do agree that with information available to you, I really do believe, though, that money is not the only thing we have to leverage, as we've talked about for this last little bit, is we've got some knowledge and we've got some staff. So that's to me, our biggest opportunity. Again, the world according to Joan, money is not happening right now. Wait about 5-10 years, it'll probably come back.
Okay. Oh, 5 or 10 years seems a long time away.
It is, because you lose so much of what you gained in the previous 5 or 10 years.
Yes. Okay, we've got a lot of questions coming in, so I'm going to save my last question. One question is, how do you address individuals resistant to change or out-of-the-box ideas other than just awaiting for them to retire?
So
Carrie and Shelby, you want to take that first?
I can, because we've kind of had this transitional thinking within our department. One time, a long time ago, I was at a public health conference, and that leader at that time made a statement about moving people off your bus that shouldn't be on your bus, and don't be afraid to moving people off your bus if they're not traveling in the right direction that their bus is going. And so I grabbed onto that philosophy and built our agency around making sure, that our staff have the right vision, have the right mindset. And we've even gone as far as in our hiring process, we ask different questions to make sure that we do bring the right people on the bus that have the same vision and the mind thinking of where we want to be.
And I would say in the climate of today, it's scary because maybe we think that they're not thinking about change, but you really know what's in the back of their head, that my health department isn't going to look like this in 5 or 6 years. So, approach somebody. I think of them as maybe they're fearful. They're fearful for, the loss of that in their community. Like some smaller communities fear the loss of their schools, and in many of us smaller agencies, you've had long time staff that have been there. So it's like, the idea could paralyze you of going forward into something new, because I know my friend may lose her job. Mm-hmm. So I think, approaching people carefully, but it's important. And it's important to acknowledge that fear.
Yep. Joan, how about you?
My first reaction is, do I resemble that remark? Been around a little while. No, I'm like, you probably need to approach them slowly and listen and ask what they would see as their role in this change. But it also depends upon where this person is you're waiting to retire. If they're the boss, you're kind of had a little problem. And it may be talking to your boards or other folks around you to get a consensus that this is where a good fit would be for us in the future, rather than sticking in the past. If they're not the boss, job descriptions is another platform to think of. When you're hired in your job description, those other duties as assigned. This may be one of them, and let's try it and be willing to listen to input. We talked it out between boards of health, boards of supervisors, and staff. So to have them understand that jobs were secure, wages were okay, and then you just meet with folks. You work side by side, help them learn that the process is a little different. Try to be approachable. I mean, I'm up there 1 day a week just to be there. And so is my nurse supervisor. She's there a different day of the week. So we do have a presence there.
Very good. So next question. What kinds of barriers or concerns did you experience from individual health departments when you first introduced the concept, and how did you address those? Carrie and Shelby?
I can say sometimes again, being smaller, the first concept is, okay, are they just going to take over and do this for me? Or, you know, am I going to have to find a portion of somebody else to do this? And so there's again, fear around that. And if my money goes somewhere else, you know, then I have a loss of control over my income or my revenue stream.
Yes.
And for our piece, so being the primary lead agency, we had to be very diplomatic and very open-handed when we went in to our communities and made sure that we understood the dynamics before we just injected what we wanted to accomplish or what our vision was. We really needed to move together with the local community rather than you shall do this type of attitude.
Thank you.
Mm-hmm.
All right, next question. What are opportunities for public health departments to partner with primary care providers? Well, we have you, Joan. Do you want to go?
Sure. I think of our First 5 Healthy Development opportunity where we partner and try to collaborate with the local health providers to have them do the developmental screenings for the children. And thankfully, we have one person dedicated to that she can meet with each clinic every month to remind them that we're here.
Do you want to add to her answer?
So we also have the First 5 with the integration with our primary care. What's really kind of a dangling carrot for our area is we have a very robust maternal child health program.
Oh, keep going, Carrie.
And through our partnership and our network and now the trust level with our healthcare organization.
Everybody frozen but me.
We actually are looking at maybe having some deeper integration so far as that they would offer a contract with our region to do public health services in like a medical home type model. Since the hospital system has their benchmarks around child exams and immunizations and flus, we really have aligned our strategies to be more of an extension of those clinics and those emergency rooms out in the community. So we want our biggest thing is we want to be that first call from our primary care.
Very good. All right. So our next question is that there's been a mention of a couple of partners external to public health departments. Can you describe kind of the organizations you're able to partner with and how their participation has benefited your public health programs?
So I can take this. So we have kind of formulated ourselves as being that first central point of contact. Like I said, we are an anomaly that we have a lot of programs under the health department's jurisdiction within Webster County, and we're trying to mirror those out into our neighboring communities to align elderly care, to align coordination for mental health regions, to align our child health population, to align daycare services, a coordination for the child care nurse consultant. The biggest piece is if there's an issue going on in our community, we want to be that community partner that is first called. And then we have a resource guide and a list of partners that we then can connect with, like our Early Childhood Iowa, our CAP agencies, food banks, housing authorities. Our vision or our responsibility here then is to connect back to that provider. With the new payment structures around ACOs and the networks and all of their requirements, they are needing that now. And so they are looking right now for that kind of one-stop shop. And my voice has always been call your public health agency. And so, we're really trying to strive that when they do call our public health agencies, anybody within our neighboring communities, that they say yes. So that's kind of the overall vision of what we're trying to accomplish. Mm-hmm. Yes. Yep.
Awesome. Joan, do you have anything you want to add?
Oh, and just to name a few of some of the programs, WIC is not in my house, so they are a separate agency. Obviously, we partner with them tremendously. A lot of the area home visiting programs, whether it's early Head Start, parents as teachers, we call them Growing Strong Families. We partner with them tremendously. The schools, churches, any kind of group that's willing to, that we can help, we will. Again, like Carrie, our human services departments aren't local anymore. The main office is regional.
So our last question, I have a couple to choose from. Let's see. So are local hospitals contributing financially to local public health as part of an accountable care organization, or is your work just goodwill, is the question.
Well, I can speak. The hospital in Hamilton County is a critical access hospital. So the answer about financial support from them is no. We do get a lot of referrals and we communicate really well, and we have actually just implemented a brand new program where we are providing all the first visits to all the moms who deliver babies at that hospital. But as far as financial directly from them, no.
Okay.
So we just started this discussion around sustainability with our hospital ACO steering committee, and we have implemented an employee share contract with the Berry Hill Center, which is a mental health entity based off of our hospital ACO structure. And that we implemented that at the beginning of January, and that now is being mirrored with some clinics. So indirectly through contract management and sharing of staff, we will be able to sustain some of the community care coordination pieces that are coming out of our hospital and our clinics and our Berry Hill Center. So we just dipped our toes in this water, so we'll see how this goes.
Oh, I just thought of something though. I met last week with our hospital discharge planner, and they really need to work on their repeat hospitalizations. And we used to have like a telehealth system, and we weren't getting good response with that. So now we kind of let that contract lapse, but we still have the equipment. And now the hospital is really interested in implementing telehealth, thinking that it'll help with their repeat hospitalization. So we might be negotiating how to get that contract back up and running since we have the equipment. But if they want it, they'll have to help share the cost.
Okay. Joan, how about you?
Taylor County does not have a hospital. There are hospitals surrounding us in all the other counties. So our partner to the north in Adams County, that was part of our partnership to take over their public health and home health, that the hospital also has a wellness center. They gave us an office in the wellness center for our branch office. That hospital also has clinics in 2 of our population centers in Taylor County, obviously, as well as in Adams County. So we help each other back and forth. If I have back in the day when we had the emergency preparedness money to buy vaccine refrigerators, we buy it for them and have an agreement that says if our vaccine storage fails, then we're storing it in yours, and I will buy your refrigerator for that.
Great. So we have reached the end of the hour. Oh, if you could just give me one sentence about sharing of services before we go, from your perspective. That's my final ask.
Oh.
All right.
Go first before I play out.
Go, Joan.
Take a chance and share. It could work out.
Very nice. Carrie.
It's critical to sustain the public health network, to start looking across county lines. Be a good neighbor.
Okay.
I would say take a risk and your residents will benefit from it.
Very nice. You all three are rock stars in my book. Kate, I'm going to turn it back to you.
Special thanks to our panelists and Joy, our moderator, and to all of you for joining us today. In a few days, you'll receive an email including links to the archive webinar, which will be posted on our website, www.mtic.org. Also included in the email will be an evaluation for the webinar. We ask you fill it out. It's only going to take a minute or two, but it'll help us enhance our future webinars. Please join us next week on Tuesday, March 27th at 12 p.m. Central for the third episode of the Leadership in Practice, a Digital Exchange webinar series entitled Using a Data Query System for Public Health Application. Thank you again, and everyone have a wonderful afternoon.